พร้อมนะครับโอเคครับก็กลับเรียนท่านอาจารย์ชลเกียรตินะครับแล้วก็ท่านผู้มีเกียรติแล้วก็ทีมพี่น้องรังสีรักษาทุกท่านนะครับที่อยู่ทั้งที่ในห้องส่งนะครับแล้วก็ที่ในห้องประชุมนะครับแล้วก็อยู่ทางบ้านนะครับสำหรับวันนี้นะครับงานของเราก็ประชุมกลางปีนะครับก็เป็นงานที่จัดทุกๆปีนะครับซึ่งก็จะเป็นงานที่เราก็จะได้อัปเดตความรู้ที่ทันสมัยกันนะครับทั้งส่วนของทางแพทย์เองครับของทางฟิสิกส์เองแล้วก็ของทางนักรังสีด้วยนะครับครับตอนนี้ก็ก่อนอื่นก็คงขออนุญาตกล่าวเริ่มต้นคร่าวๆก่อนนะครับถึงภาพรวมของงานวันนี้นะครับซึ่งงานวันนี้เนี่ยจริงๆก็ตามตารางที่ทุกท่านก็น่าจะมีอยู่แล้วนะครับก็คือจะในช่วงแรกก็คงจะเป็นพิธีเปิดนะครับจากนั้นก็ในเซสชันแรกเนี่ยจะเป็นเซสชันที่ทางสมาคมรังสีรักษาของเรานะครับได้จัดร่วมกับทางฟาโรนะครับก็จะมีเกสต์สปิเกอร์นะครับจาก Mayo คลินิกที่โรเชสเตอร์นะครับดร. Breenนะครับจะมาเลคเชอร์ให้เราซึ่งงานนี้ก็จะเป็นงานเดียวกับที่ถ่ายทอดไปทางเอเชียผ่านทางช่องทางของฟาโรนะครับแล้วก็ต่อจากนั้นก็จะเป็นสปอนเซอร์เซสชันนะครับของทางบริษัทอิเล็กตานะครับจะเป็นโปรเจกต์ใหม่ๆที่ทางสมาคมของเราเนี่ยจะมีจัดร่วมกับทางอิเล็กตานะครับก็คือจะเป็นโปรเจกต์สเปกตรานะครับชื่อฟังดูหรูหรานะครับเดี๋ยวเราลองมาฟังรายละเอียดของโครงการนะครับว่าโครงการนี้เป็นยังไงนะครับแล้วก็ซึ่งเป็นโครงการรับรองว่าเป็นโครงการที่ดีๆแน่นอนพูดเรื่องเกี่ยวกับเรื่องของ practical radiotherapy technique for breast cancer นะครับซึ่งทางอาจารย์พิชยาพรจากเชียงใหม่นะครับจะได้มาเล่าให้เราฟังว่าปัจจุบันนี้ทาง breast cancer เนี่ยมีเทคนิคอะไรที่น่าจะสามารถอัปเดตให้พวกเราได้ฟังแล้วก็ประยุกต์ใช้ในแต่ละสถาบันได้นะครับแล้วก็ในช่วง 11 โมงกว่าๆนะครับ 11 โมง 40 ก็จะเป็นเรื่องเกี่ยวกับข้อบ่งชี้เกี่ยวกับการเบิกจ่ายทางรังสีรักษานะครับซึ่งปัจจุบันในปีนี้นะครับก็จะเป็นปีที่มีการปรับเปลี่ยนข้อบ่งชี้ทั้งของกรมบัญชีกลางแล้วก็ของทางสปสช.ด้วยซึ่งเดี๋ยวทางทีมอาจารย์ก็ได้มาสรุปให้เราฟังนะครับจากนั้นก็จะเป็นสปอนเซอร์เซสชันอีกส่วนหนึ่งนะครับของทาง Variant เรื่อง Flash Radiotherapy นะครับซึ่งก็เป็น Hot Issue นะครับเป็น Hot Topic หนึ่งนะครับซึ่งอันนี้เราก็ได้รับเกียรติจากดร.ดิภักคุณเทียนะครับซึ่งเดี๋ยวดร.ดิภักดร.คุณเทียก็จะมาสรุปให้เราฟังนะครับว่าตัว Flash Radiotherapy เนี่ยมันจะมีที่ใช้ยังไงนะครับหรือว่าบทบาทมันจะมีต่อไปยังไงในอนาคตนะครับแล้วก็โครงการ Cancer Anywhere ครับซึ่งอันนี้ก็เป็นโครงการที่ทางรังสีรักษาเนี่ยก็มีส่วนร่วมด้วยนะครับก็จะมีวิทยากรจากสถาบันมะเร็งนะครับมาช่วยสรุปให้เราฟังนะครับว่าโครงการนี้ที่มาที่ไปเป็นยังไงภาพรวมของโครงการจนถึงณปัจจุบันเป็นยังไงแล้วก็อนาคตของโครงการจะเป็นยังไงนะครับซึ่งก็แน่นอนครับก็จะมีภาพรวมเกี่ยวกับทางรังสีรักษาด้วยซึ่งก็ทำให้เราเห็นภาพรวมแล้วก็เห็นโอกาสในการพัฒนาอย่างต่อเนื่องต่อไปนะครับแล้วก็ไฮไลท์ก็จะเป็น2เซสชันสุดท้ายนะครับจะเห็นว่าไฮไลท์เรามีแม้กระทั่ง2เซสชันสุดท้ายนะครับเกี่ยวกับเรื่องของ SBRT ของ lung cancer แล้วก็ของ liver ครับก็คือทั้งที่เป็น primary แล้วก็ทั้งที่เป็น metastatic ด้วยนะครับซึ่งครับอันนี้ก็น่าจะใกล้เวลาสมควรแล้วนะครับก็ขอเรียนเชิญอาจารย์ชลเกียรติขอประเสริฐนะครับนายกสมาคมนะครับได้กล่าวเปิดงานนะครับแล้วก็ครับขอเรียนเชิญอาจารย์ครับ
ครับก็ขอบพระคุณอาจารย์จักรพงศ์ประธานฝ่ายวิชาการผู้แสนขยันทำงานหนักนะแล้วก็กลับเรียนอาจารย์เพื่อนแพทย์แล้วก็น้องๆทุกท่านนะครับสมาชิกสมาคมรังสีรักษาก็อาจารย์จักรก็ได้เล่ารายละเอียดของวันนี้ไปแล้วแต่ว่าผมอาจจะลองเล่าภาพรวมของสมาคมในงานที่เราทำผ่านมาในสักปีหนึ่งที่ผ่านมาถ้ามองเป็นภาพรวมเนี่ยเราก็สมาคมเนี่ยเรามีหน้าที่ที่จะช่วยอัพความรู้แล้วก็เป็นตัวกลางแล้วก็เรื่องความสัมพันธ์ระหว่างสมาชิกสมาคมก็เป็นเรื่องที่สำคัญในแง่การอัพความรู้อย่างเช่นว่า decision management เนี่ยเราก็มีงานประชุมรวมทั้งงานประชุมวันนี้แล้วก็งานประชุมใหญ่ประจำปีหน้าของเราเนี่ยเราจะจัดที่อยุธยานอกจากความรู้ที่เข้มข้นเหมือนเดิมแล้วเนี่ยเราอาจจะมีอีเวนท์ที่สำคัญที่จะระลึกคุณครูหรือว่าช่วยเสริมความสัมพันธ์ระหว่างสมาชิกอย่างเช่นเราจะล่องเรือกันแม่น้ำเจ้าพระยาเราจะมีทีมประกวดชุดไทยไนท์อาจารย์ท่านไหนที่มีชุดไทยอยู่ที่บ้านนะครับเอามาวัดตัวใหม่แล้วก็อาจจะต้องตัดใหม่หรือยังไงก็ตามก็เตรียมตัวสำหรับงานสมาคมที่อยุธยาปีหน้าครับมีนาปีหน้า ทีนี้ในปีนี้เนี่ยในเรื่องความรู้เนี่ยถ้าสมัยก่อนเนี่ยเวลาผมจะอัพความรู้มันก็จะมีความรู้ที่สำคัญอันหนึ่งของเรื่องรักษาก็คือเราดูคนไข้เราตัดสินว่าคนนี้เราจะรักษาไงแต่ว่าสกิลอันหนึ่งที่สำคัญมากก็คือการคอนทัวร์แล้วก็การดูแพลนซึ่งการคอนทัวร์หรือดูแพลนเนี่ยพอเราจบ Resident ไปแล้วเนี่ยถามว่ามีใครมาสอนเราอีกก็ไม่มีก็แล้วก็ Resident เนี่ยเวลามาเรียนเนี่ยก็เรียนกับอาจารย์3 วันเดียว Resident บางคนอาจจะไป elective บ้างแต่ก็ได้ดูกับอาจารย์ต่างสถาบันอยู่แค่ไม่กี่วันหรือบางคนอาจจะพอมีฐานะหน่อยก็อาจจะไป elective ต่างประเทศปีนี้เราจะ break the boundary ก็คือว่าเราจะมีโปรเจกต์พิเศษที่อาจารย์กลางได้กล่าวไปก็คือ Spectra Project ซึ่งเราได้รับการสนับสนุนจากรัฐบาลญี่ปุ่นก็จะเป็นคอร์สที่ดูเรื่องคอนทัวร์อาจารย์ที่สามารถเข้าร่วมได้เนี่ยทั้ง Resident Non Resident ก็จะได้เรียนทั้งในสถาบันต่างสถาบันนอกจากนี้ได้เรียนกับอาจารย์ต่างประเทศด้วยก็จะมีRT จากญี่ปุ่นที่มีชื่อเสียงมาจอยกับเราเราก็ได้รับการสนับสนุนจาก THASTRO ซึ่งเดี๋ยวในชั่วโมงถัดไปก็จะมีรายละเอียดอีกทีเพราะฉะนั้นอาจารย์หรือว่าน้อง Resident เนี่ยเตรียมแค่อย่างเดียวคือเตรียมเวลาทุกคนสามารถจอยได้ฟรีแทนที่จะต้องไปลง e-controlling class ในต่างประเทศเราก็สมาคมก็จัดให้ฟรีเลยแล้วก็กำลังดูว่าจะขอ CME ได้อีกหรือเปล่าก็น่าจะได้ครับในการพัฒนาด้านอื่นเนี่ยด้านเครื่องมือก็อาจารย์อาจจะได้ยินโปรเจกต์ใหม่ๆจากหลายๆโรงพยาบาลอันนี้ก็ต้องขอบคุณอาจารย์ในสมาคมทุกท่านที่ช่วยกันพัฒนางานรังสีรักษาไม่ว่าเครื่องมือนั้นจะอยู่ที่ไหนมันก็เป็นทางเลือกที่ทำให้คนไข้รังสีรักษาของเราเนี่ยมีการรักษาที่เหมาะกับเขาเหมาะสมมากที่สุดเราก็ต้องขอบคุณบริษัทเครื่องมือในประเทศไทยด้วยที่ก็ให้การสนับสนุนสมาคมมาตลอดแล้วก็ช่วยกันพัฒนางานรังสีรักษาในประเทศไทยพอเรารักษาคนไข้เสร็จแล้วเรื่องที่สำคัญอีกเรื่องหนึ่งก็คือเรื่อง reimbursement ในปีนี้เนี่ยสมาคมก็สำเร็จในการเจรจากับกรมบัญชีกลางในขณะที่ราคาเบิกจ่ายรังสีรักษาเนี่ยเราไม่ได้อัปเดตมา10 กว่าปีเราก็สามารถเปลี่ยนแปลงราคาที่สะท้อนต้นทุนที่แท้จริงได้แล้วก็เพิ่มอินดิเคชันหลายๆอย่างกับกรมบัญชีกลางส่วนสปสช.ถึงแม้ประกาศราคาใหม่แต่ว่าก็รู้สึกเรายังต้อง work out กับทางสปสช.ต่อไปเพื่อให้ได้ราคาที่เหมาะสมสะท้อนต้นทุนที่แท้จริงเหมือนกับกรมบัญชีกลางแล้วก็ในแง่ international relationship เนี่ยข่าวที่สำคัญมากก็ตั้งแต่2 ปีที่แล้วก็คือว่าประธานฝ่ายวิเทศสัมพันธ์และภาพลักษณ์องค์กรอาจารย์อิ่มใจก็ได้เป็นFARO President Elect แล้วก็กำลังจะขึ้นเป็น President ตัวจริงแล้วก็ในปี2 ปีข้างหน้าเราก็จะมีงานสำคัญระดับอินเตอร์ในประเทศไทยทั้งงานร่วมกับTHASTROแล้วก็งานร่วมกับFAROแล้วก็สุดท้ายผมก็ขอบพระคุณอาจารย์รังสีรักษาทุกท่านแล้วก็ชาวรังสีรักษาทุกท่านที่ช่วยกันพัฒนาสมาคมของเราให้เจริญก้าวหน้ารุ่งเรืองจนมาถึงปัจจุบันขอบพระคุณครับ
ขอบพระคุณรองศาสตราจารย์นายแพทย์ชลเกียรติขอประเสริฐนะครับท่านนายกสมาคมนะครับที่ได้กล่าวเปิดนะครับแล้วก็ได้สรุปผลงานแล้วก็กิจการที่เกิดขึ้นนะครับในปีหน้าแล้วก็ปีถัดไปนะครับให้พวกเราฟังนะครับเพื่อไม่ให้เป็นการเสียเวลานะครับก็เดี๋ยวขอต่อเนื่องเข้าสู่เซสชันแรกเลยนะครับก็คือจะเป็น Joint Session ของ FARO แล้วก็ THASTRO นะครับเป็น Educational Session เรื่อง Update Management in Glioma WHO Grade 2 and 3 นะครับซึ่งเซสชันนี้จะเป็นเซสชันที่เราจอยกับ FARO นะครับจะเป็นเซสชันภาษาอังกฤษนะครับสำหรับ Moderator จะเป็นผู้ช่วยศาสตราจารย์แพทย์หญิงอาชิรยาเตยาธิตินะครับขอเชิญอาจารย์ครับ
Hello, good morning, our FARO committees, our FARO and THASTRO attendees. Welcome to the 26th FARO webinar. My name is Dr. Achiraya Teyateeti. I will be a moderator for this session. First of all, may I invite Professor Imjai Chitapanarux, President-elect of FARO, to give a greeting.
Hello, good morning from Chiang Mai, Thailand. I'm pleased to welcome you to the 26th FARO webinar, which is organized by Thai Association of Radiation Oncology, or THASTRO. This is part of a series of FARO webinar which aims at providing knowledge to our FARO member countries for the benefit of cancer patients in Asia. The discovery of molecular analysis of IDH mutation and 1p19q co-deletion has led to a profound shift in the way that glioma grade 2 to 3 are classified and how treatment decisions are made. This webinar today will fulfill your knowledge by Assistant Professor William Breen from Department of Radiation Oncology, Mayo Clinic, Minnesota. Thank you very much for your contribution to FARO, Dr. Breen. And I would like to thank THASTRO and also IROS for the cooperation and make this webinar is international consistently with the name and the mandate of the FARO itself. I thank you very much, and I wish you all a very successful webinar today. Thank you very much.
Thank you, Dr. Imjai. Before I introduce our speaker, I would like to remind all attendees to mute your microphone. If you have any question, please type in the Q&A box. We would have time for Q&A at the end of the session. If you experience any technical difficulty, please send a message in the chat box. And please note that a record of this session will be posted on the FARO website. And now I'm pleased to introduce our guest speaker, Assistant Professor William Breen. He's a radiation oncologist from Mayo Clinic, Rochester, Minnesota, USA. He graduated from Mayo Clinic School of Medicine and pursued his residency training at Mayo Clinic as well. Currently, he is a chair of a CNS research group and a principal investigator of many research. He has more than 40 publications and abstracts in focusing on CNS, hematologic malignancy, and thoracic malignancy. His publication included in the Red Journal, Journal of Neuro-Oncology and Neuro-Oncology. Today, he will give us a talk about update management in glioma WHO grade 2 to 3. Please welcome Dr. Breen.
Thank you very much, Achiraya. Let me share my slides here, and can you confirm with me that you're able to see the slides? Do I need to switch it around here? Can you see the slides?
Yes, okay, please start.
Okay. Well, thanks again for the very kind introduction. My name is Will Breen. I'm a radiation oncologist at Mayo Clinic in Rochester. I'm really grateful for the opportunity to join you all and talk to you today. I haven't had the chance to visit your beautiful part of the world yet. I hope I get to someday and maybe meet some of you in person and see the places where you and your patients live and work. Here's some of my disclosures. I'm employed by Mayo Clinic, and we do have a proton center. So as we get into some of the discussions and we talk about ongoing trials looking at the value of protons, which at least in North America is a fairly controversial thing, I think it's important to know whether the person that's speaking has access to them or not, and I do. So that's a bias that exists. I trained here and I work here. Otherwise, I did some consulting with GE Healthcare related to some PET tracers used in the brain that aren't related to this talk at all. And I will briefly acknowledge, I won't say support, but off-label use of IDH inhibitors in low-grade glioma as we get to discussion of the Indigo trial towards the end. So here's a picture of Mayo Clinic in Rochester, Minnesota. We got our first snow here a couple weeks ago this year. The snow is melted now, but we have many months ahead of it looking like this with snow here. So probably a little bit colder than where you guys are currently. In this talk today, I'm gonna, first of all, as was mentioned earlier, I'm gonna go into a little bit of the background so that we can understand the modern classification of glioma and some of the changes that we've had with molecular testing and genetic testing and how that influences the way we think about treatment for these patients. We'll talk about the classic treatment paradigms in order to set the stage for how things are changing, what are the current directions we're looking at, and also to contextualize some of the modern clinical trials. And then we will look at some very recent data and current trials that will likely define our practice moving forward. and then posit some future directions that the field may go. In this talk, I'm going to talk about primarily grade 2 and 3 IDH mutant glioma, so not going to get into some of the more rare things like brainstem glioma, optic pathway glioma, etc. That would be another talk. So first, for the background, as we all know, brain and central nervous system tumors are not the most common type of tumor that we see, but you know, especially in younger cohorts, they're often very lethal and cause a great deal of morbidity and mortality. So it's the #1 cause of death, at least in the United States, birth to 19 years, and second in the next highest, the next youngest cohort are brain and CNS malignancies. And so while they're less common, they are lethal and they cause a great deal of problems for our patients, and we need to work on improving our outcomes. Historically for these, gliomas have been classified by histology. So by a pathologist looking under the microscope, and we need to contextualize that when we think about all these old clinical trials. They all used histology for inclusion. And so modern treatments and modern trials won't perfectly reflect the old trials. We use these 4 classic criteria: mitotic index, endothelial proliferation, nuclear atypia, and necrosis. Quite a bit easier to remember than the algorithms used today for diagnosis. And over time, genetic and molecular characteristics have been integrated alongside classical histology. So it's important that they haven't replaced classic histology, they work together. So right now we're kind of in a mixed picture between the old school pathologic methods as well as the newer school genetic and molecular characterization of tumors. So, sorry, I'm just trying to move this out of the way. I don't know if you see it. So the modern classification of glioma, the first place to start is that oligodendrogliomas, as were historically histologically classified, are IDH mutated and 1p19q co-deleted tumors. And so they're now molecularly defined tumors. They can be either grade 2 or 3. And this is all according to the 2021 WHO classifications. Astrocytomas, on the other hand, are not 1p19q co-deleted, and they would typically have loss of ATRX. There's some testing now where loss of ATRX is seen. 1p19q doesn't even need to be tested. The diagnosis is over. It's an astrocytoma with ATRX. Glioblastoma are IDH wild type and grade 4. So IDH wild type grade 4 glioblastoma is now the diagnosis. IDH mutant tumors can be grade 2, grade 3, or grade 4 astrocytoma. So there's now grade 4 astrocytoma IDH mutant that's not a glioblastoma. These patients we know would have historically been treated on glioblastoma trials, but have much better outcomes than the IDH wild type glioblastomas. They're kind of an orphan right now in terms of how do we treat them? Do we treat them like glioblastomas? Do we treat them like IDH mutant tumors? And even within our group in our department, we have 7 or 8 people who treat brain tumors in our department. And within us, there's variability in how to handle those grade 4 IDH mutant astrocytomas. Another very important factor is the CDK N2AB deletion. In IDH mutant tumors, that's the most important prognostic factor. And so if patients have homozygous deletion of that marker, that automatically moves them up to a grade 4, which we'll talk about a little bit more. So this is a bit of a complicated algorithm here, but I think it contains mostly all the information that I just mentioned. And so I show it here, and I'm happy to share these slides too through Achiraya if anybody was interested. But essentially, the first thing we do when we have a glioma of some type is we check the IDH status. If it's IDH wild type, we're here and we have some histologic features. It's a glioblastoma. That's the same tumors that have always been called glioblastoma. If there isn't those histologic features, they can have these other molecular features of GBM like EGFR, TERT, 710 to meet that diagnosis of glioblastoma versus some of these H3 diagnoses that we won't get into as much today. On the other side, on the IDH mutant side, if they're 1p19q co-deleted, they're oligos. If they've lost ATRX, they're astrocytomas. Either of these can be grade 2 or 3. Astrocytoma IDH mutant can also be grade 4. And if they have CDKN2AB deleted, then they're grade 4. So that's a lot of information really fast. I have this piece of paper printed out by my desk just to make sure that I'm keeping it straight, and I think you can't review it enough times. This paper here that I have the citation in the corner from Neuro-Oncology really describes how they came to these diagnoses for the 2021 WHO classifications, and again summarizes those things that we just discussed. That astrocytoma can be up to grade 4 IDH mutant. Glioblastoma is always grade 4. Oligos can be grade 2 or 3. There's been some conversations about whether there should be a grade 4 oligodendroglioma. Many of you in the audience have probably anecdotally seen these oligodendrogliomas that act like a grade 4 tumor, that are very, very aggressive, locally recurrent, and have shorter survival. And so, you know, I won't be surprised if eventually we do have a grade 4 1p19q co-deleted entity at some point. What did the CDK N2A marker come from? It's a lot of letters and hard to remember, so you know, I hope it's an important one. This study here of over 2,000 IDH mutant patients from 9 different institutions showed that a little bit over 1/5 of them had homozygous CDK N2A deletions, and those patients with those deletions did worse and actually much worse, as you can see here. Progression-free survival of 91 versus 31 months, and overall survival of 154 months down to 61 months. So getting into the magnitude of IDH mutation itself, how prognostic and predictive that is. So this is a really important one. And for us within the IDH mutant tumors before 2021, we had started to kind of use this as one of our decision points on whether a patient could undergo observation after a gross total resection or not. But now the WHO classifications have caught up to reflect the importance of that marker. And this is just to show that it appears to be a very important marker, basically in all groups and all studies, and especially within IDH mutant tumors. So which markers should we look at here? In summary for grade 2 and 3, we should look at the IDH, EGFR, TERT promoter, chromosome 710. Basically, we're doing this to find out, is this a glioblastoma or not? Next, we should look at 1p19q and ATRX to find one or the other, to find if it's an oligodendroglioma versus an astrocytoma. And then finally, as just discussed, the CDK N2A should be looked at as a very important prognostic factor to see whether it's a grade 4 IDH mutant tumor. So what are the implications here? Historical trials, when we're looking at why we use a dose and fractionation for a given tumor, those trials were based on, you know, histologic grading without IDH status. And so we have to give a little bit more thought to just doing doses based on grades, which is what we're still often doing in clinic, but I think will be an evolving target as we move forward. There are some unclear areas about how to treat them after the 2021 classification. For IDH mutant tumors, should we treat them all with 54 gray or less, including a grade 3 or grade 4? I've never treated a grade 4 glioma with 54 gray, but maybe we'll learn that if they're IDH mutant, that's the right dose to use with time. Glioblastoma IDH wild type, should we take them all to 60 gray, even the ones that are histologically appearing lower grade, the so-called molecular GBMs that previously would have got lower doses? We are treating all these to 60 gray, at least in Rochester. So beyond the molecular findings, there's also quite a lot of potential for imaging. All pathologic diagnoses depends on how much you've sampled, and we know there can be quite a bit of heterogeneity within tumors as there's different cell lines evolving and going different directions. And so the power of radiomic tools, different imaging methods to help us prognosticate patients and understand the biology without pathology and without anything invasive will become increasingly important. This is one of the most kind of basic for this talk, grade 2, grade 3 glioma imaging findings that many of you may be familiar with, the T2 mismatch. So this is on a T2 MRI. And as many in the audience know, so when you see this very characteristic finding where there's T2 hyperintense and T2 flare is only bright at the edges of the tumor, that's pretty much 100% chance that that's going to be an IDH mutant astrocytoma. I've never seen that not hold, and there's a number of papers, including the one listed below, that discuss this. Of course, it's not 100% sensitive. There's going to be many IDH mutant astrocytomas that don't have this finding, but once you see it, this is the thing where our pathology colleagues will say, we're going to put them out of business because we don't need them to diagnose what this tumor is going to be. There's other imaging that may help us with target delineation and better understanding of biology. This is from a patient that we enrolled on a clinical trial of 18F-DOPA, which is an amino acid PET scan. And as you can see, oligodendrogliomas just light up like a light bulb. We'll be submitting this to ASTRO this year, but it seems to be a very sensitive imaging method for this. And what could that be used for? Why is that helpful? Well, first of all, to detect multifocal disease. And secondly, if there's quite a large area of T2 abnormality, and we think some of it's edema and some of it is tumor, the PET scan may help to know what's tumor within there and what may need a higher dose or even no dose if it was just edema. But this is all still in the research realm. And finally, spectroscopy. Looking at the ratio of the choline to the NAA here is specific for tumors. So you can see on this side where it's bright on the spectroscopy, you would have a higher ratio than you would over here. And we don't do too much of this, but there have been circumstances where we've utilized it, and other institutions certainly use it more. And so spectroscopy is another imaging method that could potentially be used to help us identify where the tumor is in a given patient, if there's biologic changing within a patient or progression. So getting into the standard treatment with some older and more recent studies of grade 2 and grade 3 glioma. The general treatment paradigm, as we all know, is maximal safe resection followed by adjuvant treatment with radiation, chemotherapy, other systemic therapies, a combination of those. So surgery for low-grade glioma, the thought here is that we know it provides us a diagnosis doing the resection, and we strongly believe that it improves outcomes. However, there's never been a definitive randomized controlled trial asking exactly this question about resection for improving outcomes. There's a good bit of prospective and retrospective data, though, that strongly hints that having less tumor around is a good thing for patients. So the low-risk arm of RTOG 9802, they saw a direct correlation between residual disease with the risk of recurrence. There's a systematic review of 35 retrospective studies that looked at the relationship between resection and overall survival. Of those 35, 26 of them showed that increasing extent of resection directly correlated with improved overall survival, whereas only 6 showed no correlation between resection and survival. The remaining studies were a little more ambiguous in their findings. This is a study that I really like here, looking at the role of surgery. It was a retrospective study, 228 patients. They used semi-automated software on the T2 sequences to define the volume of residual disease. And then they looked to see if that correlated with overall survival, especially in astrocytoma, which it did. And even very small amounts of postoperative tumor appeared to impact overall survival. So whenever your surgeon, if there was just a biopsy and you're kind of questioning, should we go ahead with radiation, or if the surgeon feels that they can safely resect more tumor, especially in the case of astrocytoma, we often encourage them to do so. So here is some of their survival curves based on the amount of residual disease. And here you can see in overall oligodendroglioma and astrocytoma that the blue line, no residual disease, has the best outcomes, which wouldn't surprise you. I think the most striking part of this is here in the astrocytoma curve, panel number C here. You see that the blue line, no residual disease, is much better than even this one that has 0.1 to 5 cc's of tumor. So getting rid of all of the detectable tumor on surgery seems to be a very positive prognostic factor. Of course, sometimes they can't, based on the anatomy or other patient factors. This is a difficult to look at set of figures here, but basically what it's getting at is it's using different cut points of cc's to split whether there's an improvement in overall survival. So this, we just talked about if there's no disease left versus 0.1 or more, it's very clear there's better overall survival. But the question this is getting at is, well, if you can't do a GTR, is it still worth debulking tumor? And you can see here, all the way up to 20 cc's of tumor, there's still a significant overall survival benefit to having less than 20 cc's versus more than 20 cc's. So what this tells me is that if the choice is between doing some debulking versus biopsy only, we would prefer there be debulking, whatever can be safely resected. And then there was a Norwegian study that looked at 2 different hospitals, one who used biopsy only and one who used resection, and they treated all the patients in their area. So it's not randomized, but it's only dependent on residential address. And they had 153 patients, and they had significantly improved survival in the hospital that did resection rather than biopsy. So just another indication that we would support surgery in these patients as much as we can. So classic adjuvant treatment, following resection, we base treatment based on the risk. And the risk is based on either the RTOG factors, which is patients less than 40 years old who have had a gross total resection. And so if they have no neurologic symptoms, no seizures, those patients have, by some been safely observed. And we'll get into that a little bit more. Or by the EORTC, the European factors, if they have none or limited to the factors, again, 40 years old, astrocytoma histology, a big tumor greater than 6 centimeters crossing the midline, or preoperative neurologic deficits. These come from old studies from the 90s and 80s, but some of these things can still be useful for us. So the EORTC study, they randomized patients between 54 gray and observation in patients with low-grade glioma. They were histologically defined, and they saw that there was a significant difference in progression-free survival with radiation, but no difference in overall survival. And so, when we talk to patients that are in this group, we talk to them and there's about a 2-year difference in median progression-free survival by doing radiotherapy or not. And maybe more importantly, some of the other differences that we see is that there's less seizures with radiation over time. And also, there's no increase in the rate of malignant transformation. There was a time when a lot of neuro-oncologists, including some of those at Mayo Clinic, were worried that radiation for low-grade tumors was going to spur their transformation into higher-grade tumors. And we know that, TMZ, there may be some concern for that, but with radiation, we don't have evidence that it speeds malignant transformation. So that's not a reason to withhold radiation. And again, there are less seizures the radiation arm, even in these most favorable patients. And we already mentioned the RTOG 9802 group, where they looked at low-grade glioma patients. They didn't randomize here. There was 110 of them that they watched. I like this. I find this to be a helpful number in clinic, that 5 years after surgery, about half of them were free of progression. And you can see that in these graphs here, that those among that group with unfavorable risk factors had higher risks of progression or lower progression-free survival. And I want everybody to make a mental note of this one. So patients who have 1 cm of residual disease here, they're the dotted line. So you see how poor they do in terms of progression-free survival, with a very, very small amount free of progression here and at 2 or 3 years. And so some would say that that would make a standard arm in this situation chemotherapy and radiation rather than observation. But as we'll get into later on modern studies, some have considered these patients with more than 1 centimeter residual disease observation to be a standard of care arm. So what's the right radiation dose? Essentially the long and short of it here is that dose escalation does not appear to help. There's an EORTC study looking at 59.4 versus 45. No difference in overall survival or progression-free survival. Smack dab, overlapping lines, no improvement. Maybe a slight bit more radiation necrosis with the higher dose, as we might all expect. Similarly, we recently updated the NCCTG trial that looked at dose escalation for low-grade glioma, 64.8 gray versus 50.4. And again, no difference whatsoever between the 2 arms for progression-free survival or overall survival. Here are these 2 curves from our SNO presentation on this. again, getting out to even 20 years of follow-up for these patients. And this is how long it takes to do low-grade glioma studies. It takes 15, 20 years of follow-up, which is inherently going to be a bigger problem as our therapies advance quicker and we're coming up with new things quicker. We have to wait a long time to get definitive results. And by the time those results come, the initial trial question may no longer be relevant. But again, no benefit to dose escalation here. The good news with this is that even with the higher dose, later radiation effects like radiation necrosis or serious toxicities were not seen. So it does appear that treating gliomas to glioma range doses is a safe thing in the long term for patients. This was also an encouraging finding from this very long-term analysis. Out to 15 years, patients were stable on their mini mental state examination. Of course, this is not the most sensitive neurocognitive battery that we have or we could use now. And that'd be another talk talking about current advances in neurocognitive batteries for patients. But to stay focused on this, with the data we have, it appears that they were neurocognitively stable. And so getting radiation didn't appear to have these drastic neurocognitive effects, which again, on modern trials that we'll talk about later, was used as the justification for delaying and avoiding radiation therapy. One more look at long-term neurocognitive outcomes. This was just published here a couple months ago. A German group looked at 71 glioma patients that they did really nice serial neurocognitive testing on, and they didn't see decline in any cognitive domain from baseline to follow-up in these patients, and they didn't notice any difference between patients who got radiation versus patients who were observed with watchful waiting. And we know that that's, if there was worsening with radiation, which there can be, that seems to be washed away by the loss in progression-free survival. And as we all know, tumor progression certainly has an impact on neurocognitive outcomes for a patient. In terms of dosimetric correlates, they noticed that ipsilateral hippocampus dose did seem to matter. So patients who were getting more than 50 gray to the hippocampus on the side of the tumor had worsening in half of the domains, whereas if they had less than 10 gray to the ipsilateral hippocampus, then they had stability or even improvement in all the domains. So obviously, the reason you have radiation dose to the hippocampus is because there's tumor there. And so, there's going to be some selection issues here. But to me, this is also an indication that we should be cranking on our radiation planning to minimize dose of the hippocampi and other structures that are important for cognition and memory when we're doing our radiation planning for low-grade glioma. So this is how we do it at Mayo right now for glioma, generally speaking. And of course, there's exceptions to this, but our general approach to dose and fractionation for grade 2 oligos, we're doing 50.4 and 28. And typically it's the T2 to define the GTV with a 1 centimeter CTV. And for all these, we'll use a 3 millimeter PTV if we're using photons. Grade 2 astrocytomas, we'll go to 54 and 30. If it's reasonably sized, we'll use lower doses for the more for larger, more expansive lesions with 1 centimeter. For grade 3 gliomas, whether it's astrocytoma or oligodendroglioma, we're typically using 57 gray and 30 fractions as an SIB with a 51 gray and 30 volume to a 1.5 centimeter expansion. The more common dose you'll see for this is the cooperative group doses of 59, 40, and 33 with a 50.4 and 28 lower dose with sequential boost. So of course, these are both appropriate methods. And for grade 4 gliomas, whether they're IDH mutant or glioblastoma, we're doing 60 gray and 30 fractions typically for our younger patients with good performance status and doing 2 centimeters of 51 and 30. If you've heard anybody from MD Anderson talk about radiation doses, you'll see the same kind of 30 fraction pattern of 54, 57, 60 from them. And that's because we both had Paul Brown at our institution in the last 20 years. He's kind of led the rationale on those doses. Of course, we'll manually edit these CTVs where it makes sense. So if there's T2 that's going more than 1.5 centimeters beyond the enhancement and it looks like tumor rather than edema, of course, we'll include that in the CTV. And then we anatomically constrain all CTVs. These are general organs at risk. Nothing here that I think is too earth-shattering to anybody. Here we look at these and we try to really use our beam angles, as I'll get into a little bit later with protons, to minimize dose to the hippocampi, frontal lobes, and other tissues wherever we can, to try to avoid these very typical acute and long-term side effects. Chemotherapy, just to move very quickly, we know this, RTOG 9802 showed improvement in overall survival with PCV chemotherapy, and oligos may benefit from that the most. Similarly, and this was true in the IDH mutant patients when they looked at that, because obviously IDH mutation wasn't available in 1998 when the trial was started. And similar findings were found in the EORTC study. So in anaplastic gliomas now, that was grade 2, which is the majority of these patients. Anaplastic gliomas, which are more rare, and a number of them historically have been IDH wild type tumors, meaning that they're now categorized with glioblastoma and not really in this category. So we'll move a little bit more quickly. They're much more rare. We need to look at the molecular characteristics to see which ones are GBMs and which ones are IDH mutant. Looking at some of the older data with these, you do have some 15-year median survival in the anaplastic oligodendrogliomas, assuming these are IDH mutant 1p19q co-deleted. So they're acting a lot like grade 2s in some senses. With all that being said, there still does hold prognostic value to grade 2 versus grade 3, which is why that still exists in the 2021 WHO classification. PCV here with 9402, it does improve outcomes significantly, similar to how 9802 did in the grade 2 patients. And this was done on both the RTOG side and the EORTC side to show that it improved outcomes. And so for us, for gliomas, for oligodendrogliomas, we're typically doing PCV. And for astrocytomas, we're often doing TMZ. And it's sometimes that simple. The neuro-oncologists will have those conversations with patients, but I think there's a lot of institutions where they're doing TMZ for most everybody. And of course, we're awaiting the results of CODEL, which is, as of the Alliance meeting a couple of weeks ago, is finally just about done accruing, where we'll see the answer for co-deleted patients, whether TMZ or PCV is the preferred chemotherapy. Just to keep moving here so we have time. Anaplastic astrocytomas are also poorly represented on a lot of these trials. Many will treat them like glioblastomas because they were included on the classic STOOP trial. And it's, of course, TMZ is easier to give than PCV. There are trials of using where they use concurrent and adjuvant TMZ with radiation, like RTOG 9813, where they compared it to BCNU and CCNU. It worked about the same in terms of survival, but better toxicity than BCNU, CCNU. A single-arm trial by Mike Vogelbaum of just 47 patients where they did temozolomide until progression and then did temozolomide and radiation seemed to work okay. So again, for the grade 3 astrocytomas, we're often treating them with temozolomide and radiation. And then it gets to the current question of, well, are you giving concurrent temozolomide with radiation for grade 3s or just adjuvant? And that's another topic where we have pretty significant variability within our group even. And a lot of that is based on the CATNON trial, which is a great trial of almost 750 non-co-deleted anaplastic astrocytomas randomized between 4 arms. Radiation alone with 5940, radiation with concurrent TMZ, radiation with adjuvant TMZ, radiation with both concurrent and adjuvant TMZ. And getting into some background on this, the assumption from the investigators and many others was that the concurrent TMZ may be the winner here, that concurrent TMZ, it's really the radiosensitization of TMZ that matters. The adjuvant may not be adding much. I think that many thought that this trial may eventually allow us to drop the adjuvant TMZ for anaplastic astrocytomas and just use TMZ as a concurrent drug. And, the results in this trial teach us why we do randomized trials, because even the smartest people's assumptions are very often wrong, even in things that they've spent their career treating and learning about. And so the adjuvant temozolomide is where the benefit was, not concurrent temozolomide. And there was no benefit to current temozolomide, regardless of them being IDH mutant or IDH wild type, which brings out some maybe provocative thoughts about glioblastoma, whether we need the concurrent temozolomide or it's just the adjuvant temozolomide that's important. In our practice, we still do give concurrent temozolomide often. Here are the curves for Catinon showing with the adjuvant temozolomide in blue here, significant overall survival benefit compared to no adjuvant temozolomide. Whereas when we look at the concurrent temozolomide over here, no difference whatsoever between the concurrent or no concurrent temozolomide. So in general, for anaplastic gliomas, they get a maximal safe resection with neurologic preservation, which is as much as they can safely get. And then we'll treat with adjuvant radiation and chemotherapy. We don't observe any grade 3 gliomas, even if they're younger than 40 and had a complete resection. There might be others, particularly at Stanford, who think that some of these can be observed. That hasn't been our practice. We typically treat these to 57 gray and 30 fractions. And then the chemotherapy, you can go a lot of different directions with these, with PCV, with just adjuvant temozolomide, with concurrent and adjuvant temozolomide. There's a whole bunch of different directions you could go with a straight face with chemotherapy with these. Recent data and future directions to continue with this. So current trial that's going on right now is actually very close to closing. I'm really proud of the fact that this has been able to accrue so that we can learn from this important question. But this is a phase 2 randomized study for patients with IDH mutant grade 2 or 3 glioma, and it's protons versus photons. So 54 gray, either one, with VMAT versus protons, and the primary endpoint here is neurocognitive endpoints. There's a whole battery of neurocognitive testing that's better than some of the older cognitive testing, but maybe not the digital testing we would use in 2023, but still going to be helpful to see our protons really helping. Do the pretty color washes mean anything clinically? And that's an unanswered question at this point. And of course, they'll also look at secondary endpoints like toxicity. Lymphopenia may end up being different based on glioblastoma studies and others, quality of life, progression-free survival, etc. And as I mentioned, this one is just about done accruing. And a couple of years afterwards, we'll have neurocognitive endpoints and be able to report that, which is really exciting. Thinking about the difference between protons and photons, this is a recent patient of mine where I made a proton plan and an IMRT plan. You can see I did use a contralateral beam here. We'll talk about that later. I'd be very interested in hearing what some of those in the crowd that may have access to protons do with that. But you can see here that the benefit isn't in the area where we're treating really with protons. The benefit is the further away uninvolved brain getting less low to moderate dose. So this is the 12 gray at the edge of the blue here, out here. And so the right hippocampus is getting less dose, less low to moderate dose. Does that matter for neurocognitive endpoints or other endpoints? We don't know. That's why we're doing the trial to try to learn. We know that it reduces dose. We don't know that that changes outcomes at all. So a case example here of another recent patient, 33-year-old guy, presents with seizures, found to have a T2 hyperintense left frontal lesion and has a subtotal resection performed. And this shows a grade 3 astrocytoma IDH mutant. So you can all kind of think in your head, this patient's coming to tumor board, they've got a subtotal resection. What are you going to offer in terms of radiation? What are your volumes going to be? You want to do chemo? What would you recommend? And as I mentioned, there can be a lot of right answers here, but I'll just talk to you about the way we did it. This red here is a higher dose GTV that included some enhancement after surgery and the cavity, that expansion on it. This blue line here includes the T2 hyperintensity, and then we have a margin on that out to CTV here. So this is the area we're treating. And for those who do have access to protons, think about, would you do a contralateral beam or not for this one? And what would be the benefits of doing it or not? So this is how I did this one. Here's our high dose isodose line, which of course looks pretty if you just look at that. Looking at the lower isodose lines, you can see we have one beam coming here and one beam coming here. The benefit of this is that we spare any dose from the other side of the brain and the frontal lobes. The downside is that we have a higher biologic dose. And when I say biologic dose, so that's the end of range depositing of dose or higher LET dose, essentially getting at the fact that the Bragg peak at the end of the proton's range, it's going to have more than 1.1 times as much dose as the photons at that point. So it deposits extra dose, it packs an extra punch biologically right there. And so by doing it this way, you are pouring out this hotter biologic dose where the end of range of these two beams come together. And we have noticed that, especially in the periventricular tissue, where you have this higher end of range dose, they may be at more risk for at least two T2 changes, maybe radiation necrosis. And so that would be a rationale for adding a contralateral beam. And you just have to think of, is it worth it for this tissue that you're completely sparing over here versus the higher biologic dose at the end of range. So for this patient, again, like I showed before, I did the contralateral beam so that we wouldn't be end of ranging out in the optic chiasm. You can see in the light blue where my chiasm contour was here. And we could keep the biologic high dose. That this is calculated by an in-house model that we use, but there's other ways to do this too. But we keep that end of range out of the optic structures, out of the brainstem if we're in that area. And so that's why I used a contralateral beam, accepted some dose right here. There's other cases where I've decided not to. So this is a meningioma, a different type of tumor, but just to show a case where, in this one we went with the case without using the contralateral beam to spare the left hippocampal dose, even though there was a little more end of range biologic here without the contralateral beam, we're able to keep that out of the optics for the most part. And so why did I think about it in that one? Well, it seems that the left hippocampal dose is particularly important. And that's probably because for a lot of people in their brains, that's where a lot of the language and speech processing is, and that's what helps them do well on the neurocognitive tests, but that's also what helps them do well as a functioning member of society. And so this was just a study of glioblastoma, so different population where they did short course in glioblastoma, but they did some dosimetric predictors of toxicity and of their cognitive outcomes, which is just significant differences in cognitive outcomes based on left hippocampal dose. And so based on that maybe shaky evidence, I at least try to keep the dose out of the left hippocampus whenever I can. And now to the controversial recent thing. I don't know how much you guys are talking about this in your daily practice, but we're talking about it plenty. So this is the Indigo trial. It was published in the New England Journal of Medicine here just over 2 months ago. This is a randomized phase 3 trial of the IDH inhibitor or vorasidenib versus placebo in residual recurrent grade 2 glioma. So this pill is an IDH1 and 2 inhibitor. IDH1 is over 95% of cases, but it also does IDH2. And it's a pill that they take once daily until progression or unacceptable toxicity. And so, as a drug company would love, you take it indefinitely. It's shown to decrease the metabolite of IDH, of the actual enzyme, which is 2-hydroxyglutarate. And by inhibiting IDH, you get rid of this metabolite here, and it changes some of the gene expression changes that happen in IDH mutant gliomas. So there was good basic science, preclinical evidence that this might work. And as you can tell, it did work, and we got some, a lot of hype in the lay press, at least in the United States, about how excited people were about this. Inclusion criteria for this trial is pretty tight. So 12 years or older, they had to have residual recurrent grade 2 glioma, not grade 3. Could be astrocytoma or oligos, no brainstem involvement, at least one prior surgery within 1 to 5 years, and they can't have had prior radiation before. They had to have at least 1 centimeter of measurable non-enhancing disease, but no enhancing disease. They had to be asymptomatic and a candidate for watch and wait. Now, based on some of the previous data I showed you, there'd be some that would say, well, this doesn't make sense. If they have a CC of non-enhancing disease, that means they should get radiation. They shouldn't be a candidate for watch and wait. And so the control arm for this trial shouldn't have been observation. It should have been standard chemotherapy and radiation. That would be one argument that people make. But these are the findings, and this is why this is in the New England Journal of Medicine. Vorasidenib improved progression-free survival quite a bit here, 11 months to 27 months. So you see the curve just kind of hangs on there for us for about 9 months before dipping below, but still very significant hazard ratio and p-value. This is not overall survival. This is a receipt of next intervention, which of course is pretty well correlated with progression-free survival. And they haven't reached that yet with vorasidenib here. The reason they don't show overall survival is because no patients had died yet. And that's because there's only 14 months of median follow-up on the study, which, we look at low-grade glioma studies, they take 10, 15, 20 years to often tell us what we need to know. And so just over a year of median follow-up, it is awesome that we're seeing this progression-free survival benefit, but it's not giving us enough information, I would say, to totally change things. It did seem to help in all subgroups. Looking at adverse events here, very important. So there is a non-trivial increase in liver toxicity. So more than 10% of patients are going to have grade 3 liver toxicity on this. Patients also can't be having children during this time. These are often young patients who have this window available. And so we don't know that it improves survival, which matters to patients. We don't know if it improves quality of life or longer term outcomes, functional outcomes for patients, which matter to patients. And so there's reason to be cautious. All that being said, of course, the bottom line is that it's great that we have another treatment that seems to work for low-grade gliomas, for IDH mutant gliomas. Now we need to know when to use it. Are we going to follow the specific inclusion criteria on the trial that didn't include grade 3? They can't have had prior chemo or radiation. They can't have any symptoms. We talked about the short follow-up here, that there's no deaths and we don't have neurocognitive data. And again, the other concern that I've heard from some is that we don't know that once patients develop resistance to these IDH inhibitors, how they'll be changed biologically and how they'll then respond to standard radiation and chemotherapy. And so whether there'll be any negative long-term biologic effects of this. For us in the United States, we're waiting approval of this drug, and our neuro-oncologists have been, some of them have been pretty eager to use other IDH inhibitors that are approved for things like leukemia. There's some for cholangio too, which wasn't the drug that was tested, and also being used in situations that it wasn't necessarily used in the trial. And I think as radiation oncologists, we have a tool that we know works. And so I think, really need to advocate caution in getting carried away with this exciting new drug and using it when it might help, but not in place of treatments that we know increase survival and progression-free survival, decrease seizures, and maintain function for patients. Of course, there's future trials looking at this in other settings with grade 3, with IDH mutant grade 4. There's a trial coming through Alliance in combination with radiation and chemotherapy. These are all things that we're going to learn in the coming years. And if you guys ever invite me to talk again, hopefully we'll be talking about some of those things. Here's a busy slide that just shows one way to think about how to guide adjuvant treatment for grade 2 glioma. If they're symptomatic or asymptomatic, they can get maximal safe resection. If they're classic low risk by the RTOG category here, they can go to observation or vorasidenib. But if they're higher risk for any of these things, symptoms greater than 40, subtotal resection, then we would recommend doing radiation therapy with chemotherapy. The chemotherapy can be PCV or TMZ, as we learn about that. Radiation can be protons or photons. We don't need to dose escalate. And so I went over a little bit past what I think I was supposed to talk. Very happy to take any questions. Again, I'm really grateful for the opportunity to talk to you all, and hope I get a chance to meet you in person someday. Thank you very much.
Thank you, Dr. Breen, for your excellent and informative lectures. Now it's time for Q&A for the on-site attendee. If you have any question, please come to the microphone. For the online attendees, please type the question in the Q&A box. There's some question. The first question is, do you routinely cone down your target volume at Mayo Clinic?
Sorry, do we do what at Mayo Clinic?
Do you routinely cone down the target volume?
Yeah, we typically don't. So our approach is typically using a simultaneous integrated boost. I don't think one way is wrong and the other way is right. But for example, if we're going to 57 gray is what we'll use in 30 fraction for our grade 3. We have our low dose volume is 51 and 30. And so we'll have the bigger volume going to 51 gray and 30 and the smaller volume going to 57 gray and 30. And the reasoning behind that is that you're making it in just one plan. The dosimetrist and the optimizer is doing it all together. And so then inherently, you're going to hopefully do the best job of accounting for all the objectives within the optimizer to the OARs and the targets. That being said, you can have great sequential plans, and I still have used sequential plans in many situations, but typically we're not doing a cone down, we're doing a simultaneous integrated boost. Thanks for the question.
About the criteria of the maximal subtotal resection.
Yeah, yep. So the paper that I showed to me, so a lot of the older data, it's like when we think about medulloblastoma, they talk about 2D measurements of residual tumor, and now a lot of the modern studies use radiomic methods to give us volumetric numbers. And I think it's a different question for astrocytoma and oligodendroglioma, how much resection we want to get. For astrocytoma, some of those curves showed that any bit of residual disease seems to confer a worse prognosis. And so if you can get that last CC out of there for astrocytoma, a complete gross total resection, even in the non-enhancing disease, that seems to be worth it. And so going for re-resections, I think, is not wrong when it can be safely done. Whereas with oligos, it seems like resecting more is better, but they do so well with radiation and chemotherapy. There seems to be less of a benefit of being super aggressive with surgery. So I think, in those cases, we're maybe a little more lenient with the subtotal resections and less eager to go back in for a re-resection, even if it might be safe.
So because molecular testing may take weeks we have to wait for the results. So the question is, how long can we wait after the surgery to the radiation or adjuvant chemotherapy based on the interim result of Canon?
You are asking me a question that makes me very frustrated every week, because even at a place where I think our lab does a great job in their molecular testing, Jorge is my pathologist friend, and he may not think of me as his friend, because I am always harassing him for when are the molecular tests going to be done, especially when it's a GBM and you want to get going relatively quickly, or a higher grade glioma, and especially when you're trying to enroll the patient on a trial and they need to meet inclusion criteria. And so, ideally, all these things, as the assays get better, will get to us quicker and will come with a diagnosis or within a few days. But it's sometimes 2-3 weeks that we're waiting for all the information that we need for this molecular classification. And I have in some cases, started treating with 1.8 gray per day, knowing that I might adjust my final dose based on molecular markers that come in when I don't feel like we should wait. And so you touched the nerve there. I totally agree. We need to get faster results on these things.
So, and how about your opinion about the malignant transformation for both either temozolomide or the radiation group? Because some studies said that the malignant transformation is maybe higher in the chemotherapy alone group. Yes.
Yeah. So I agree that there does not appear to be compelling data for malignant transformation with radiation. I think that there's been, of course we don't know, and in some cases could that happen? Sure. It doesn't appear from some of the watch and wait data comparing observation to radiation. They have the same rate of high-grade recurrence and malignant transformation. It doesn't appear that radiation caused it. However, there does appear to be a subset where temozolomide causes, these hypermutation profiles and does cause malignant transformation. Of course, on average, it doesn't, because temozolomide improves outcomes on average for that population. Hopefully, we'll know which patients are at risk of that and when we shouldn't do it. But for us, that's a reason why we never, at least in our group, we never do just radiation or just chemo. If we're going to do adjuvant treatment, we do radiation and chemo. We don't just do chemo and wait a while for radiation with the temozolomide, for some of those concerns. And so it's, they go together from our perspective. I saw there was a question about what dose for the SIB, what's the dose per fraction for the high and low dose. So for our glioblastoma, where we're going 60 and 30, that's 2 gray, and then 1.7 gray for the low dose volume, the 51 gray. For grade 3 glioma, where we do 57 gray, it's 1.9 gray, 1.7 gray. And then if we're doing an SIB for a grade 2, then it'll be 54 and 51, so 1.8 gray and 1.7 gray. So it just goes up 0.1 gray per fraction as the grade goes up by 1.
There's a question, is there any subgroup that we use 12 months of adjuvant temozolomide?
Good question. The 12, when are we doing 12 months of temozolomide? That is really neuro-onc driven, but for us right now, we're really mostly doing 6 months of adjuvant temozolomide. I haven't seen a patient in any subgroup get 12 months of adjuvant temozolomide in a little while, but in some of the, I don't think it's unreasonable to do it, and I've seen it done plenty. But right now we're doing 6 months.
In the FARO room, and we are running out of time. I have to choose some question. Okay, are you routinely give oral steroid during the radiation to minimize the side effect?
Yeah, great question. So we don't do oral steroids unless we have to, is the short answer. If there's a reason to do it symptomatically, of course we'll give them some dexamethasone, but we don't, and if we don't have to, if the symptoms haven't told us we have to, for a couple reasons. One is, we all know long-term corticosteroids is really rough on people's quality of life, their sleep, their mood, their blood sugar, their weight. And then also, I don't think that there's a huge immune component to the treatment of low-grade glioma, but just like we think of in other cancers and we're becoming more and more trained, dexamethasone suppresses the immune system. If the immune system's helping us at all, we'd like to avoid doing that. So we're only doing dexamethasone when patients have symptomatic swelling.
Okay, this will be the last question. In case that the astrocytoma grade 3, after receive surgery and radiation, 2 or 3 years later, they develop the transformation to grade 4. What about your recommendation, treatment recommendation in this case?
Yeah.
Do you consider re-irradiation, and what dose?
Yep. Re-irradiation, unfortunately, is a situation that we're in for almost all these patients, because we're not curing patients, unfortunately. And so if it's in-field, if it's an in-field recurrence, a high-grade in-field recurrence, we use 35 gray and 10 fractions. So the RTOG 1205 recurrent glioblastoma dose, we will use that. We don't re-irradiate until basically all the systemic therapy and surgical options have been exhausted, so we have the biggest duration between radiation courses. If there's an out-of-field recurrence, if they recur not within the prior radiation field, but somewhere out of field, then we're often taking a hypofractionated 15 fraction course. So 40.05 gray and 15 fractions for an out-of-field recurrence versus 35 gray and 10 for an in-field recurrence.
Okay, as we are running out of time, I would like to conclude this session. Dr. Breen, thank you very much for your excellent and informative lecture, and thank you for our participants to join this session. Have a good day and enjoy your weekend. Thank you.
Yep, thank you very much. Thanks, everybody. And please feel free to email me, my last name dot first name at mayo.edu with any questions. Thank you very much.
Thank you.
Okay, bye.
ขอบคุณนะครับทางวิทยากรนะครับดร.วิลเลียม บรีนนะครับแล้วก็ Moderator นะครับผู้ช่วยศาสตราจารย์แพทย์หญิงอชิรยาเตยาธิตินะครับก็เราก็จะมีเลคเชอร์อย่างเงี้ยนะครับก็ขอบคุณทางทีมฟาโรผู้ประสานงานทางฟาโรนะครับแล้วก็